Good morning and good evening, depending upon where everyone is. From Los Angeles, this is Jerry Green. I'm the president of the Pacific Council on International Policy. I want to introduce you to our event today, which falls within a broader set of interests that we have, which is healthcare diplomacy. The worse things become globally, politically, the more important healthcare diplomacy is. And if it didn't take a pandemic to remind us, we certainly should be reminded. So this is enormously important. I want to introduce our speakers, beginning with Dr. Omar Najim, who is the executive director of the executive office director at the Department of Health in Abu Dhabi in the United Arab Emirates. Dr. Najim reports to the chairman of the Abu Dhabi Department of Health and the Abu Dhabi Public Health Center, and he's one of the primary leaders shaping the landscape of healthcare in Abu Dhabi. I was in the UAE not that long ago in the midst of the pandemic, and with some chagrin, I felt somewhat more comfortable there than I did in Los Angeles. Everyone was vaccinated, masked, and nobody was complaining. So I think we really do owe congratulations to the UAE. The main role of the Department of Health, where Dr. Najim is operating out of, is to basically promote the healthcare sector and have it to achieve its full potential. There's a motto underlying their work, a healthier Abu Dhabi. And Dr. Najim is a member of a 6-member core Abu Dhabi Healthcare Gold Command Team for COVID-19. And we'll be speaking about his impressions and his experiences today. I am equally as pleased to introduce Dr. Soniya Gandhi, who is an infectious disease specialist and vice president of medical affairs and associate chief medical officer at Cedars-Sinai Hospital. Cedars-Sinai and the Pacific Council have a very close relationship. Art Ochoa, a senior member of the Cedars staff, is a member of our board of directors. We work very closely with Dr. Haitham Hassoun, who runs the global health program at Cedars, and Cedars really is the gift that keeps on giving and is at the heart of much of our city-to-city diplomacy. Dr. Gandhi been in her current role since July 2021. She oversees patient safety, hospital epidemiology, medical staff governance, and various quality initiatives. Prior to her current role, Dr. Gandhi held a number of leadership roles at Cedars-Sinai Marina del Rey Hospital, including Chief Medical Officer from 2018 to 2021 and Chair of Infection Control from 2016 to 2021. During this time, Dr. Gandhi led several quality initiatives, including rebuilding the peer review process, alignment of processes with the Cedars-Sinai health system, and championed a multidisciplinary team to drive sepsis compliance, which has remained consistently in the top 10% of hospitals nationally. As you all know, the heart of the mission of the Pacific Council is global LA. And as I was telling Dr. Gandhi, Cedars-Sinai is kind of the Hollywood of health. Everybody knows about certain things that we do, certainly the Rams. We're very big on sports diplomacy as well. But Cedars-Sinai in the health sector is the gift that keeps on giving. And as I say, the more turbulent the world becomes, the more important it is to address healthcare initiatives, particularly as we're entering, we hope, the final stages of the COVID pandemic. Drs. Najim, Dr. Gandhi, on behalf of the Pacific Council, thanks to you both, and I will now get out of the way and let you do your work.
Thank you very much, Joel. It's an absolute pleasure to be with you today, and it's an absolute pleasure to be joined by Dr. Gandhi on this occasion. I'll be waiting for my cues or... Yeah. So if we can put this on presentation mode, if that's okay. Good then, Sean. So while we're preparing the presentations, I think it's just to give you a glimpse of where I come from. So today, what we're going to do is just take you through some of the experiences gained on COVID-19 response and some of the lessons learned going forward, and potentially just highlighting some of the elements that we're going to do as we go into the recovery phase and prepare for the next pandemic, so to speak. So Abu Dhabi makes one of the 7 Emirates of UAE. So Abu Dhabi constitutes about 60% of their landmass. It's also the capital of the United Arab Emirates. We take care of a population of 3 million that lives and resides in Abu Dhabi. We also take care of a population, the wider population across the UAE, which is about 10 million. Just to tell you why Abu Dhabi experience is unique. So thankfully, over the last 2 years, we've managed to get into a pandemic and response to it in a way that provided us with, most importantly, one of the lowest 5 mortality rates globally in terms of number of cases and in terms of death. I'll highlight how did we manage to do that. We also had a 0 day of lockdown. So we had some restrictions about movement. We had some telling the individuals or the population that we take care of to take caution and apply the non-pharmaceutical interventions like washing hands, wearing masks, keeping healthy distance. And also over possibly over the last year, because of the number of cases we have and because of the very high rate of testing, we continue to have our infection rate ranging way below 0.5% all the way through, including the recent Omicron wave, as well as the waves before. Now, you don't need to take our word for it. At the end of the day, I think there are some objective assessment being applied by different ranking houses, including Bloomberg, who continue to put UAE as the #1 resilient country globally. Deep Knowledge Group from London putting the city of Abu Dhabi specifically on the #1, as well as the many other ranking that I don't want to bore you with. If we go to the next stage. So what we call it, so most of the countries or systems usually look at responding to the pandemic in 3 main ways, which is the prevention, which is about breaking the chain of infection from transmitting to 1 person, to 2 person, to 4 person, to 10 people. So a lot of what we did is focusing on the front end of the response. A lot of the response happened there. Second is treatment. If somebody gets infected, obviously you need to provide the best of treatment and systems and processes in order to prevent them, A, from getting into the hospital, 2, from getting into ICU, and 3, from dying, obviously. And last but not least is how do you apply your vaccination program? We always say vaccines by itself, albeit it's a fantastic innovations and a fantastic victory for science that it got. Several of them got developed within 10 months of the start of the pandemic, do not save lives by themselves. What saves lives is the vaccination program. Effective. Most countries and localities has applied one way or the other, similar to what we're describing in one way or the other. What makes a difference is what we call, if we go into the previous page, what we call the applications of a tapestry, where you apply the governance and the leadership and the lessons learned there. We will go into the digital research and innovation role and how it got applied, the collaborations that we take away from this, and the communications and marketing. So if we go into the next one, what you have is always responding to a pandemic doesn't start on day 0 or day 1. It starts way before. What are the things that you have put in place? One of the things that we're fortunate and being prepared in Abu Dhabi is just before the start of the pandemic in December or January 2020, is we already established the Abu Dhabi Public Health Center, taking the lead in responding to any future challenges around the health of the people that we take care of. We also did regular drills. We also had an assessment and upgrading of the systems in place in the collaborations with international. When the pandemic hit, we focused on 3 things that you might have also applied in different ways in LA or different other cities across the US and across the world, which is testing. The difference about testing in Abu Dhabi is we ramped up our capacity very quickly and we made it huge. So if I can tell you just yesterday, even with the number of cases being low, we did 500,000 tests. Just to put that into context, 500,000 PCR tests that get the results turned around within 12 hours as the KPI is there, is about 5% of the total population of UAE. So every 20 days, we were allowed to test the whole population fully. What also happened is we applied a 12 dedicated program to provide free testing for either people at risk from developing complications and developing severe disease, like population, like people with chronic disease, people who are elderly, people who might be, because they are smoking, obese, might be more prone to developing severe disease. All of that get for them and their household regular testing. We also did regular testing for the ones that are of high risk of transmitting the infection. So the guys who works in key industries like healthcare or aviations or transport or in retail or food and beverage, all of them get regular testing free of charge. And of course, there is a tracking and isolation. In the isolation, I just give one example that also was different in Abu Dhabi, is if somebody need to be isolated, they need to be provided with a place to isolate. If they do not have an access to isolation place within their home, they get provided with hotel rooms free of charge, or they can isolate at home, but their laundry, their rubbish, food, as well as daily allowance get provided to them on a daily basis. And that ensured that these individuals do not go out of the way to break the isolations and make a threat to the wider community. If we go into the next one. Now, moving from that, you need to support this with the treatment. So the protocol keep updating based on the latest of science. The workforce capacity got upgraded straight away. We invited retired, we invited individuals who might have not been registered within healthcare. We invited individuals who might be providing even part-time from where they work. If they work in the private or not in a dedicated facility for COVID, we ask them if they will be able to provide the extra time they have to a dedicated COVID facility. What we also did is we shield the majority of the healthcare system from COVID by having the resources and the expertise dedicated in a few places that treat COVID. So if somebody get diagnosed to have COVID in one hospital, then the arrangement is made to get that patients to the dedicated facility where the expertise and the resources are there. And that helped a lot in honing down the protocols and the pathway to the absolute minutiae to make sure that they get applied to the last bit in order to prevent people from dying. And the capacity is the same. At some point, we also triaged individuals according to the severity of the illness they have. If they're having mild or moderate, they can go into what we call field hospitals, where the average length of stay is 1 or 2 days. If they are more severe, obviously they go into the dedicated facility where there are 2 in the Abu Dhabi city, 1 in Al Ain and 1 in Al Dhafra region. If you go into the vaccination and when the vaccination became available, I'll just give you again the story around it, and was one of the key success is we moved very early on the vaccination. Our vaccination the story started around April 2020. So it's around 2 months into the pandemic. We started collaborating and exploring and appreciating that vaccine is going to be one of the key tools to apply in order to get out of the pandemic. What we did, we started collaborating with 38 international partners from academia, from individuals, from scientists, from companies to take their hand through the development of these vaccines, either through an investment, early investment into what they are doing, or early procurement, or mounting or offering ourselves as a clinical trials. And we were successful in terms of the clinical trials. So we had one of the biggest single site clinical trials globally. Also, we did about 6 different vaccines along the way when they were developed. Some of them went on to be successful, about 4 of them. And the last but not least is offering Abu Dhabi as a place for manufacture or to fill and finish. And that was also successful, and I'll come to talk about that later. But when the vaccine became available, we moved very early based on the data that were available. We moved very fast. So our vaccination program started around October, November time. So if you remember, the first vaccine that got approved was November 2020. But because of the availability of the data that we shared with the wider world, we started a key targeted population vaccinations around October time, and we moved very fast. So within, by I think, February, March 2021, we were able to vaccinate about almost all of the targeted key priority populations, and almost 60% at least 1 dose of the population. That gave us a good headway, and you probably followed that up. We continue to be one of the highest populations, the highest vaccinated population rate globally. And then we went wide. We didn't want for the individuals to come to us to ask where's my place in the vaccine, but rather putting lots and lots of over 100 hubs where people are. So we put it in malls, we put it in neighborhoods, we put it in community centers, as well as the hospitals and the healthcare clinics that we had. And if we go into the next, and you probably had different versions of that story, which is the prevention, treatment, and vaccination. Well, we made the difference, and I'll come to that. There are about 4 slides in there. One, the first is governance and leadership. We made the governance in a way, in a hierarchy that enabled very fast and immediate information sharing, and very effective and fast executions of actions. We also put the principles around what we do, and that principles went all the way through the different layers and the different teams that were responsible for the response. So agile and fast. So what we say is a good decision taken now is much better than a perfect decision in 3 days' time. There is no time on the virus. We're dealing with something very small, but have a huge impact on economy, on society, on communities, and even on the individuals, being it the one who are infected or the one who's not infected. So we need to make decisions very fast. It needs to be science-based. From the beginning, I think most of us have appreciated that nobody at the start of the pandemic can say, I'm an expert in this. This is one of the biggest events to affect many of us in our lifetime. And it needed something to move fast, but the science need to be key. If the science is not available at the time of taking the decision, then the main thing is we move on, we take a decision on the best of the parallel science, so to speak. But nevertheless, actions need to be taken in place to develop science and evidence for the next decision that needs support. Same thing with the data. The data is not available at the time of taking the decision. We take the parallel data that can indicate which way is going, but nevertheless, we put the processes and infrastructure ready to collect these data for the next decision point. And high reliability, being consistent with the population, being consistent in the principles of taking these decisions. Next one. And then digital research and innovation, I think everybody has lived through it. You probably read it in 1,000 papers talking about how digital advanced over the last 2 years. The fact that we are meeting across the globe with 12 hours difference is a testament to that. Some of the key ones is always the population at risk, making the vast amount of data segmented according to the decision-making point. So the person at the field, the person in the hospital, the person in the top of the hierarchy, the person who's in the middle, they all need their own data and access to make decisions of their own, or to make these decisions available for somebody else in order to support in facilitating the way forward. Same thing with the research. We talked about the clinical trials that happened in Abu Dhabi. So that clinical trial was able to recruit about 32,000 volunteers. And that happened within 8 weeks. Of course, we were dealing with something that was in people's face, and that helped them to be more engaged on it. But just to put, again, that number into perspective, that number of volunteers in a single clinical trial, and more clinical trial happened after it, is more than all of the clinical trial volunteers in the META region, so Middle East, Africa, and Turkey, for the last 5 years combined. As you appreciate, many clinical trials require only 100 or 200. This one, with the way it get dealt with the evidence that ended up having that vaccine certified by WHO, was one of the best experiences to come out of this. And we got addicted to doing more clinical trials and more confidence in ourselves going forward. We also contributed over 344 research to the world around the different areas in COVID. Next one. If there is anything that we learned from this pandemic, is that collaboration is key. So collaboration is key in the sense that nobody is out of this pandemic unless everybody is out of this pandemic. What we want to show, and that was evident from the start, the collaborations that we mounted in is collaborations across professional boundaries, geographical boundaries, commercial boundaries, political boundaries. We got people and so there isn't a single entity in Abu Dhabi that says, this is healthcare, it's got nothing to do with me. Everybody has to play a role. And when you got them into the target and objective that is clear, which is saving people's lives, you will be amazed how people come together. And I'm sure we will learn more experiences from you guys on how this happened. Again, putting an example onto this, so 80% of all of the global humanitarian aid that went through during the last 2 years has passed or come through UAE, because we have the staging factor in UAE, of course, but we also have the ability to help and different countries support and take it from there, and that started paying dividends, where the quality, especially around the vaccine, is becoming evident in the countries that we are helping. Next one. Of course, you need this. None of this would have happened without the engagement of the public that we have. So the vaccination rate getting to the high level that we have, the adherence to the non-pharmaceutical intervention, the fact that people are seeking the science and taking to us, and the communication and marketing is key. Talking to people in their own language, especially with the fact you've got about 200 different nationalities living in Abu Dhabi and UAE. And with that, you need, some of them, their literacy level is not to the scope that you just give them a brochure or you put a written information for them to digest, but rather even speaking to them using influences or using visuals in the language and in the way that engage them. Next. I think I'll move very fast into the next one. So when we talk about, of course, there's always, and especially in the US and many countries around the world, there is always the healthcare front and the economic front when discussing various aspects of the response. Sorry, if we go into the next slide, the number 12. So from the economic front, it's always been the question: what is the impact today? What's the impact on people's livelihood today? Are we doing what we're doing is going to have a dip that is long lasting, or a dip with a rebound, or a dip that is short lasting and then a rebound to a different degree? All of that gets assessed according to the information. Healthcare front is always assessing and never shying away from reversing a decision if we can see that the impact of that decision is having impact on the infection rate or the admission rate or the death rate, more importantly. And these things need to be imbalanced through communications and collaborations and continuous being open in a forum that encourage this. Next one. Now, going forward, and how do we maintain the recovery? Of course, lots of data which talks about what's our public health capacity, and it's readily available, and can we ramp it up quickly, and that decide what stage we are. Community acceptance. We probably, all of us, either inherently or kind of publicly, we went through phases of pandemic fatigue. We listen to the experts, we see the numbers, but we're getting to different stages where our mental health is telling us, or our situation is telling us, this will not affect me, and I'll be going out and enjoying my life to the maximum without care of what's going to happen. Nevertheless, and also you might be thinking about your work, you might be thinking about the other areas. So there's always the element of watching out for that. And last but not least is always what's the cushion that if things like what happened in Omicron get to be ramping up very quickly and spreading up very quickly, what's the health system capacity in terms of workforce, in terms of infrastructure, and in terms of medications and resources. Now, going forward into the future, it's tracking the different metrics that we need to see. What's the infectious status? What's the public health capacity and measures? Next. We talk about the technology, but there are certain infrastructure technology that's been utilized and they proved their worth. And they went through the proof of concept. So the cloud computing, the facial recognition, the drones and the advanced analytics and AI, social media technology and the sensors. It seems that they are here to stay, not only from a COVID-19 point of view, but also from treating other diseases. And I'm sure Dr. Soniya can tell us about the latest advances that Cedars-Sinai is leading on or being discussed globally along that front. Now, for the next stage, as we were saying earlier, is preparing for the next pandemic starts today, if not yesterday. That preparedness for the next pandemic should not wait for the next case to happen, should not wait for the next country to announce that there is a pandemic, but rather an amalgamation of data into a data lake. So economic data, healthcare data, mobility data, public health data, and all of the employment data that will lead into creating data lakes that you can put disease surveillance, economic monitoring, and consumer sentiments and behavior tracking along the way to enable you to always mount an actions very quickly and take the necessary processes and apply the necessary processes in order to protect the population you have. I'll stop there, but I'll leave you then an image of Abu Dhabi skyline for the hoping next time we'll see you there.
Fantastic. Thank you, Dr. Najim. I will wait for my slides to come up, and I think that it will be a nice complement to just the broader overview that you gave. But really just, my focus will be being able to speak to Cedars-Sinai's pandemic response. So it'll be more a perspective of a health system and how we had to respond, and many similarities, I think, and many things to learn that we can get to in the conversation between you and I, Dr. Najim. So I am very honored to be here. And I will try and quickly go through these slides. We won't spend a lot of time. I have several slides, but we'll really try and ensure that there's enough time to take the audience's questions as well as a good conversation between Dr. Najim and I. We'll start with an overview, go through some guiding principles of our COVID plan, and then touch on a couple of important pieces of our COVID response, obviously, including vaccine planning, community outreach, communications, and looking ahead. If you go on to the next slide. So just to level set for those of you who may not be familiar with Cedars-Sinai, it is in Los Angeles, of course. We have 889 licensed beds, although we've consistently ran over that in terms of our admitted patients, really almost up to 1,000. And the other stat just to mention on this slide is that we've cared for over 5,000 hospitalized COVID patients since the start of the pandemic, which is the largest in the LA area. So really a nice cohort of experience at this point in time. Next slide, please. And again, for those of you who may not be familiar in the Los Angeles area, this is just showcasing Cedars catchment area, and the dark, if you call your attention to the middle of the slide, Beverly Hills, the dark maroon color, that is really the medical center, the flagship hospital, but you can see that Cedars-Sinai has expanded its footprint pretty significantly in the greater LA area. Next slide, please. So in terms of Cedars COVID response, we really came up with kind of 4 guiding principles, similar to how Dr. Najim mentioned. These were really the pillars that we wanted to focus on as we moved through our response in this pandemic. So one was to continue to preserve access to our hospitals and clinic for all of the healthcare that we've been giving even beyond COVID, and to continue to have that access. Second was, of course, continuing to protect our patients, employees, volunteers, and the community. Third was do no harm, of course, utilizing all of the latest infection control practices to ensure that there were no exposures at Cedars. And fourth is sustaining our financial stability to continue our long-term mission of the Cedars-Sinai health system through this pandemic. Next slide, please. So with these guiding principles, we really, again, similar to Dr. Najim, one of the similarities, we really had to fundamentally alter our infrastructure to handle this pandemic. So typically speaking, we have a very hierarchical model, but similar to, it sounds like what most of the world had to do, we very quickly had to shift to a team of teams approach, where we had individual teams handling a number of things and then reporting in. And this is what really allowed us to be agile, particularly in the beginning of the pandemic when, as we recall, there were new data, new information around transmissibility that we oftentimes had to disseminate very quickly and operationalize often multiple times a day. So I think if you look at the bottom left, the surge planning often got the most media attention around ensuring that we had enough beds and we had ED tents to be able to really see all of the patients that were flooding our emergency rooms. But there was much more than that, as you can see here, where we again fundamentally reorganized our infrastructure. And I think there are important lessons learned here to preserve that agility. Next slide, please. Similar again to Dr. Najim, we were very data driven. This is where, if you continue, we have some animation here, you can see we continued to utilize the LA County data that was provided every day. You can continue to click, Mariah, thank you. So we'd routinely and integrate all of the LA County information coming around cases, hospitalizations, key metrics, including ICU hospitalizations. And then recently, I think similar I saw in Dr. Najid's slides as well, we also began to look at COVID concentrations in sewage as a leading indicator potentially of COVID in the community. So in addition to all of these external data points, we also, if you go to the next slide, we're very quickly utilized our internal data. So with the help of our colleagues internally, we were tracking our COVID bed census every day, looking at the number of confirmed and suspect cases, including over time, looking at our 7-day moving average to see how we were trending. Next slide, next click, if you continue to click through. We also did very granular and a deep dive into our COVID hospitalized patients, looking at the demographics and trying to understand the chronic medical conditions of the patients that were hospitalized. And most recently, of course, looking to see the vaccination and booster status of our COVID hospitalized patients. So we incorporated and integrated data into all of our decisions, similar to Dr. Najid's comments. And I think one of the lessons learned that I'll just mention here is that, again, similarly, we had to get very comfortable with communicating with uncertainty. We did not always have data to guide our decisions, even though that's ideal state. And I think as leaders, we had to be very comfortable with, again, making the best decision with the data that we had on hand at the time. Next slide. I think as part of the communications, and what was critical was this implementation of a Cedars-Sinai Capacity Command Center. So this was an initiative that was already in flight prior to COVID, but COVID really underscored the need for this. So you can see a couple of the pictures. So this is literally a large room at Cedars with up to 20 monitors and up to 30 people, of course, physically and socially distanced appropriately. But this was really, the Capacity Command Center is what I liken to air traffic control for Cedars-Sinai. So regularly speaking, we have oftentimes up to 950 admitted patients. We have a lot of inputs into the hospital from the ED, patients waiting to be admitted, from multiple clinics all over the LA area that are within the Cedars-Sinai health system. We have transfers from other hospitals, knowing that we're a large quaternary care that has specialized services for many patients. And we also have discharges, of course, going through the day. So how do you coordinate all of these efforts in an efficient way? And this is what the Capacity Command Center really allowed us to do, and was critical during COVID for us to keep our eyes on who was leaving the hospital, how much capacity we still had, who could we safely give beds to, in addition to those unexpected admissions potentially from our operating rooms and cath labs. Next slide, please. And I'll mention again, in terms of our interfacing with larger, the state health departments, as well as the CDC, this is a framework that we look to frequently to guide us. And, you know, it's very interesting, I think, practicing in the US. And while I've practiced abroad for several years, I think it's unusual in the US and was a learning point for many of us that haven't been abroad to really function in contingency and crisis, which I think much of the world, unfortunately, oftentimes has to face in terms of shortages of space, staff, and supplies. So this was kind of a way for us to continually check with the California Department of Public Health, as well as CDC, where we could safely try and continue to offer care when we had shortages in these areas. Next slide, please. In terms of our surge plan, so traditionally prior to COVID, we had a contingency plan of being able to care for up to 940 patients. And there was a lot of effort, of course, to try and expand this with COVID. And we had a very tight surge plan up to about 1,200 patients that we could take care of at Cedars Medical Center alone. We thankfully didn't get that high, but you can imagine a lot of the ramifications of this in terms of, again, staff, space, supplies, and ensuring that we weren't cutting any corners with regards to patient safety. So this was something that we quickly did very early on in the pandemic. Next slide, please. I do want to make a comment around logistics and supplies, which was another arm of our COVID preparedness. Of course, we had a lot of infrastructure needs that we had to very quickly develop and implement. Everything from screening stations at the hospitals that were mandated both by state as well as CDC to screen staff, patients, and visitors. And prior to the pandemic, just again, by way of volume, we were seeing up to 15,000 visitors a day. So, I mean, we're talking about very, very large numbers just at the Cedars-Sinai Medical Center. We had significant investment in testing, although I think there are definitely lessons to be learned from both UAE, Dr. Najim, and elsewhere in the world. I think this is something that the US unfortunately really needed to improve upon and didn't do so quickly. But at the medical center, we were very fortunate in that we were able to quickly ramp up testing here at the medical center, and you can see some of the numbers here. And then similar again to the rest of the world, we really had to make a quick investment into digital technologies. Just again, going back to that guiding principle of ensuring and preserving access to all of those patients that sought our care outside of COVID, really optimizing video technology, virtual care. And we saw more than 500,000 virtual visits for our patients that weren't able to come to the medical center. And one of the challenges moving forward is, of course, how to really continue this arm of care that proved to be instrumental and critical for many of our patients. Next slide, please. I think supply tracking was another area that, again, we had to quickly develop. And if you remember early on in the pandemic, at least our experience in March 2020, we had significant supply issues, as did much of the world, with masks in particular, with hand sanitizer. And so very quickly, we were able to put together an infrastructure, building on the current infrastructure that we had had pre-COVID, to really track very closely hundreds of supplies, which we are continuing to do to this day, and continuing to be impacted, unfortunately, by those supply chain issues that are felt globally. Next slide, please. Of course, clinical management, I can't, when I think back to March 2020 particularly, and I keep going back to the start of this pandemic with this new virus, and how all of us were really forced to try and not only understand what data was coming around, what was coming out around best practice with these COVID patients, but how to disseminate that quickly, how to disseminate that in an appropriate way to our providers, to our nursing staff, and all of those at front lines was a real challenge. So we had a specific physician COVID team that would then teach others, and really kind of had several opportunities and venues to share that data that was emerging very quickly. We'd created a specific COVID line team to really help place any kind of lines for our critically ill patients in a safe way. And of course, we were protecting our patients and staff through new protocols around cleansing, disinfecting, physical distancing, eye protection, temperature checks, and really had to build this complete infrastructure from the ground up. Next slide, please. There was also several innovations in the nursing space in terms of how best to care for our patients. One of the magnet cornerstones in Cedars as a magnet institution is, of course, innovation and improvement. And our nursing colleagues certainly helped us with regards to this during the pandemic. Next slide. So one of the ways that we were innovative to really practically help us ensure that we had enough staff, but also take care of our employees, which of course we'll talk about in terms of the mental health impact that this has had on everyone, was the Employee Resource Bank. So for those individuals who had their quote unquote conventional or normal jobs impacted, particularly in the operative space when we had to postpone elective surgeries, we wanted to ensure that those employees stayed whole. And so we were able to quickly deploy them, reassign them, teach them, and we were able to deploy up to 1,400 employees so that they continued to obviously have a livelihood, and we were able to repurpose them so that we could continue to function and really plug the holes where we needed staff. Next slide, please. Of course, vaccine planning and administration, this was critical. We were able to get vaccines and procure vaccines in December 2020. There were very few institutions at that time that were able to do so because of the cold storage requirements of the vaccines. We had set up, and we still have to this day, a drive-through across the street from the medical center, which has the ability to vaccinate up to 20,000 Angelenos every week. So it's a massive undertaking. It's very well run. And very streamlined. We've been able to administer upwards of 100,000 vaccines that you can see here. And so we're very proud of this effort that works very well, both for our staff, the Cedars community, and for our larger Los Angeles community. Next slide, please. And then, of course, community outreach, which is a fundamental mission of Cedars-Sinai Health System. This was incredibly important. And as Dr. Najim rightly said, this was not just about, you could not be myopic in the view of your response to the pandemic. Everyone around you needed to, and we still need to work on this, which I'm sure we'll get to in some of the questions, but just how can we more equitably ensure people have access to information, to vaccines, to medications. And see, this was a big, certainly a big prominent issue for Cedars, and we were able to donate as well as have numerous educational efforts and community conversations to really combat a lot of the misinformation that was out there, and arm individuals with their appropriate information to make the best decisions for themselves. If you go to the next slide, please. I think vaccine hesitancy is something that unfortunately is a huge problem in the United States, and Cedars was able to contribute to lots of conversations around vaccine hesitancy in populations that historically were mistrustful of healthcare in general, We partnered with LAUSD, which is the school district, and very proud of the pop-up clinics in some of the more underserved areas that may not have had equitable access. And we were very proud and honored to be able to help there. Next slide, please. Communications, I think, is a huge challenge. And I would say if you were to highlight one of the biggest challenges, I would say is communication. So how do you communicate when the rapidity of evolution was unbelievable in the beginning of the pandemic, particularly? So it's not only disseminating and reaching everybody, it's how do you meet people where they are to actually have productive and constructive communication? How do you combat the misinformation? And so Cedars had an external and continues to have an external website for patient and visitor information. We have multiple email correspondences. We have an intranet site that is continuously updated with up-to-date resources for all of our staff, employees, and providers. We had multiple leadership town halls, oftentimes twice a day, to really ensure that we were able to disseminate rapidly evolving information. We continue to do this to this day, at least once a week. Next slide, please. And we also, of course, utilize social media and blogs to really disseminate information around community safety and wellness. And importantly, I think for the mental health of all of our healthcare workers, there was a lot of gratitude from young children. And these were things that were very, very, of course, well received when our healthcare workers were struggling. Next slide, please. I think in looking ahead, I'll just make one focused comment on looking ahead, and then just make a couple of just broad arching comments that that really mirror what Dr. Najim mentioned. But I think one area, just from a healthcare provider standpoint, I would say that we really need to focus on, and I think is gaining increasing attention, is long COVID. And for those of you who are unaware, long COVID is essentially after 28 days from an acute infection, the persistence of very debilitating symptoms potentially that can last for months or even upwards of years, we're finding. And what's challenging about long COVID is it's difficult to predict, although we're starting to have some evolving data around who may be most at risk of long COVID. But it also seems that the acuity of infection doesn't necessarily correlate to your risk of long COVID. So what I mean by that is even individuals with mild COVID that may not have been hospitalized could be at risk of these long-standing symptoms such as fatigue, shortness of breath, headache, brain fog. And I can tell you just personally, having a few friends that unfortunately have been inflicted with this, it's very debilitating. So very high functioning individuals who really are having a challenge to maintain kind of their regular standard of life and be able to function and work. So it's estimated at this point that anywhere from 10 to 30% of individuals with COVID are at risk of long COVID and have long COVID. So you're talking, at least in the US, millions of people that may be suffering from this. And so I think this is really, just from a healthcare standpoint, an area that we really need to focus on and pay attention to, is how best to support these millions of individuals that are having these longstanding symptoms. And then I would say on a broad level, I think just lessons learned, and I think we'll talk about this a bit, is just number one, we realize we're very adaptable. So healthcare, at least at Cedars and in the US, can be very, it can be a behemoth to make changes very quickly. And so to maintain that agility is really, what do we do post-crisis to maintain those lessons learned? How do we continue to be adaptable and agile? I think also just lessons around, obviously, technology and leveraging technology. I think we need to move forward there and make sure that we don't lose the gains we had. And then thirdly, I think the mental health crisis, and I would call it a crisis, has really come forward in terms of how we can take care of each other and our employees to both retain our workers and ensure that there's not this very hard dichotomy between mental and physical health in this country. If you go to the next slide, I think I'll stop there. We continue to, of course, use data to model COVID projections moving forward, not knowing what the pandemic is going to bring. If you go to the next slide, I believe that is my last slide, and I'll pause there for the sake of time to ensure again that we have enough time. I know that I think both Dr. Najim and I went over, but frankly, it's a very tall order to in 10 minutes to capture a COVID response that's been unprecedented and dramatic. So I appreciate the attention. Okay, so with that, I think, there's maybe I can start with a conversation with Dr. Najim. I know we only have 10 minutes, so I'm also happy to take questions from our participants and audience. So, it was incredibly interesting, Dr. Najim, just hearing the response and just kind of the forward thinking of the UAE, both with regards to vaccines, with regards to testing particularly. And I think I can say from the United States' standpoint, that's an area that many of us have been frustrated by in terms of the testing capacity, and something that I think we learned the hard way. Was there, one of the challenges that we face in the US is around vaccine hesitancy and combating a lot of the misinformation that's out there that's really taken hold in certain segments of our population. It's been interesting to see culturally how other countries have or have not had to face that as much. And I'd love to hear a little bit more about how, if at all, that was an issue around vaccine hesitancy or misinformation, and what the culture and acceptance of the public was with regards to these public health measures that you were advising.
Thank you for that, and amazing presentation from your side as well. It's great to hear the many steps that's been taken by Cedars-Sinai to provide the right care for the community it's responsible for. I think around vaccine hesitancy, it's a problem worldwide. I think that there has been several studies measuring that, the impact of that across the world. And of course, certain countries like the US and some parts of Europe, there is quite a substantial percentage of the population that has this issue. But I think it all stems down, or it can be tackled by the keywords and the elements of trust. What happened in UAE is across the first 10 to 12 months, of course, the responsible parties for the response that were at the forefront, and it was evident by the amount of resources, the amount of efforts that's been spent on getting the population to the right level, that this was no simple feat. I can recall even with the leadership input in terms of role modeling, or in terms of getting the right messages, it was key. So if I can take you back to around April time, lots of people were worried about their health primarily, about their livelihood, about the impact on the economy, on their jobs, on schooling, and all of that. And the leadership came up with a slogan, which is, "Do not worry, So what this did is telling people the food and the medicine and everything else is going to be provided free of charge, no matter who you are, no matter what type of insurance you have, no matter what residence you have. And even if you are illegal, there will be no questions asked." And that went through the first 10 months. It built a credit of trust. When the vaccine arrived, there were the key messages of why the vaccine need to be taken. So it's not only protecting the individual themselves, but also protecting loved ones, especially the elderly, and having a wider community, and going back to, so to speak, normalcy, although the time before COVID is never going to be the same as the one after COVID. But getting back to normalcy where jobs, ambitions, professional and personal growth can be pursued again. And that enabled us to get the first few weeks out of the way, where the interested party and the ones that needed to be vaccinated, especially the vulnerable, get vaccinated. Now you get to a certain percentage. And what the choice we put is, there's a pandemic life, and there is a non-pandemic life. The pandemic life is the restrictions around movement, the lockdown that happened, the ability to go to work, or to go to the mall, or go to practice sport. And if you choose the pandemic way, and it's your choice, it's never been mandated as a vaccine, like what happened in Austria, or what's going to happen, or what happened to a different degrees in the UK. It's never been mandated, but you have the choice. If you don't get vaccinated, then you have to be tested every 2 to 3 days in order to enable the green pass to be maintained. The green pass enables you to enter the different public spaces. If you don't, then it's only 2 to 4 weeks green pass, and that's moving between different places or going to schools or attending parties. And that tackled quite a good percentage of the population. Then we also tackled this through offering different choices of vaccine. Because of the engagement early with the different vaccine developers, we were able to provide different vaccines. We have about 6 different vaccines available in UAE. And that enables, so whoever doesn't want an mRNA, there is the viral vector, there is the live attenuated, there is the other vaccines, and they are different degrees, and sharing publicly with them what are the pros and cons of each vaccine, but also sharing the data around how long the immunity is going to take and what prevention of death, the degree of it is going to take. Now, if all of that doesn't happen, we're now providing the monoclonal antibody, which is the pre-exposure by EvoShield and AstraZeneca, and say, okay, if all of that doesn't work, there is another choice. And I have to say, all of it is free of charge, including the EvoShield, which runs into the thousands of dollars. So all of that got provided, and I think it built the confidence in the public that we're doing this not for the sake of doing something malign in the background, but rather for the protection of going to normalcy.
Yeah, I think a lesson learned, I would just make one comment and then we have a question, and just for the sake of time, we'll quickly go to our closing remarks after this question. But certainly, I think in retrospect, of course, which is always 2020, I think the communication mechanisms that the US had, I think the establishment of public trust in public health needed to start a lot earlier, unfortunately. And there was just so much disparate information that was coming across from authorities that I think we're still feeling that very acutely, unfortunately, today. So I'm going to pivot to this one question, and then we'll quickly go into closing remarks after this question, Dr. Najim, as we're coming to the close of the hour. There's a question here around the problem of vaccine nationalism, a challenging question. So how can we ensure a coordinated and equitable approach regarding the acquisition and delivery of vaccines?
From our point of view, it's been evident from the start, once we got the vaccine, there are many countries that got their share of humanitarian aids in terms of vaccines, or in terms of PPEs, or in terms of other elements of the response to the vaccine. But I want to say this, and UAE keeps saying it, nobody's safe until everybody is safe. You can, unless you close your borders, vaccinate your population and stay there, so to speak, as a sitting duck to when things open, you will be getting it again. So it doesn't matter if it's a small country anywhere in the world. I think equality of vaccine need to be there. However, there need to be an assessment of the infrastructure to deal with these vaccines. There's no point on giving a country a 1 million vaccine, but they are only able to move 100,000 through a vaccination program per month. What you can do is get these 100,000 and work with them on setting the infrastructure right, especially to deal with the new technology platforms that new vaccines are being developed. -80 and -20 is no mean feat. It's not a simple some liquid in a glass and sending it somewhere and that's it. Every single step of transporting, storing, and distributing these vaccines need to be absolutely right. If it goes out of temperature deviations or the security element of it is not there, that vaccine is going to be wasted. And that is the last thing that you want. Also, the other risk of that vaccine arriving and not being effective, or causing harm rather than causing good. So all of that need to be taken into account. I think the manufacturing need to be stepped up. The sharing of different vaccines need to be there. If countries have an excess of vaccines, either in the contracts or arriving already, that need to be shared in the right way. But it need to be in collaborations with the receiving country in order to make sure that the vaccination program is going to be effective as well.
Yeah, thank you for that. I will, knowing we're at 9 o'clock, Dr. Najim, I'll ask you to start with just a closing comment. And then I would just say, again, I think we're in a very interesting time period now. It's sometimes not so much getting through the crisis, but what you learn and glean post-crisis, I think that really defines how we address and move forward. So many lessons learned, need for collaboration, need for equity, and obviously lots of challenges, particularly in the US, around just regaining public health, public trust in public health, I think is a huge challenge for the US. But Dr. Najim, please, with closing remarks, and just want to say thank you to the audience.
Thank you. I think just the lifting the hat of just looking at this as a healthcare elements of the talk today, especially the presence of the members from the Pacific Council. There's a bigger impact of COVID beyond just the long COVID. I agree with you about the healthcare impact of long COVID, and we need to take care of that, as well as preparations for the next pandemic that need to be starting today. I think we've been fortunate. Science has proved its worth. So whatever investment that has gone into science that enabled vaccines, monoclonal antibodies, and other interventions to be developed in such a record time, the world would have been in a different place if that didn't happen, in a very bad shape. So I highly applaud the science elements of it. But also we need to appreciate that there are other dimensions and ramifications still to be faced going forward. There is the economic burdens that COVID has put on different government fiscal budgets, on different individuals' financial resources, as well as mental health, as well as community cohesions, as well as the shift in paradigms of powers across the world. And I think all of that need to be dealt with in a unified, collaborative approach going forward. We've seen it that the more collaborations, the more openness around collaborations happen, the more likely that the impact on the objectives of saving lives and livelihood will be taken care of by itself.
Yes, very well said, and a great way to kind of bring this hour to a close. Thank you, everybody, for participating, and thank you on behalf of the both of us for having us here. Wonderful, wonderful to hear and listen and think about all the similarities and ways we can learn from each other. Thank you. Have a good day. Good night.